Hey guys, I had to separate this in a couple different parts, and so this is part two. Basically, the next slide was a four-chamber heart, and so superiorly, um, there is a four-chamber heart level, and so here's your right atrium, right ventricle, and left atrium. And here is your left atrium, descending aorta, and here's a view of your left pulmonary artery. This is this caudal to the AP window. And so the left pulmonary artery is over here, and this is this anterior lateral to the left main stem bronchus. And here's your right pulmonary artery. And this, remember, the left pulmonary artery, which is this white arrow over here, has passed superior and descends posterior to the left main bronchus, which is right over here by the red arrow. And here's just a case. I just threw in a couple of cases this to show you guys some examples, and this is one that was in your website that was recommended. Basically, this is a patient that's a 53-year-old executive who presents to the ED with calf and chest pain and mentions how he needs to get home to his wife as he just returned from a long business trip to Japan. Probably took a flight. Just going to throw that out there. And basically, when you're taking a look at these question stems, it's just a good idea. And I'm sure you guys did this with all of your boards and just in general practice over the last, year in medical school. But, it's a good idea to just start thinking about some differential diagnoses just based off the question stem. It's also helpful, to look at the imaging, which we're going to do too. And so basically here is going to be your normal contrast opacification. And when you get into this right main pulmonary artery, you can see here that there is a filling defect. And so based on that and based on everything in the question stem, we think that this could probably be a pulmonary embolism. And so that's correct. And here's three arrows in case somebody wasn't able to see this. And for those of you guys that haven't had much experience prior to, your R1 year in radiology, which I didn't either. I wasn't previously trained or anything like that. These types of cases will jump out at you after you see a couple. But basically on this CT, you can see this massive filling defect in the right pulmonary artery, and the patient's going to need anticoagulation and possibly intervention. And so next I just wanted to briefly talk about the mediastinum. It can be divided into anterior, middle, and posterior compartments. There are some different mediastinal lines or stripes, which are interfaces between the soft tissue of mediastinal structures in the lung. Displacement of these lines can help us understand and better kind of have an idea of where the pathology is within the mediastinum, and that's why they're important. And so here's your AP window, your para-aortic line, here's your paraspinal line, your azygoesophageal line or recess, and then your paratracheal line up here. And one key thing is that the left pulmonary artery runs over the left main bronchus, while the right pulmonary artery runs in front of the right main bronchus, which is lower in position than the left main bronchus. And so your left main bronchus will be higher than your right. And so, or the left, hilum will be higher than the right hilum. And so it's really important to know. And this is just a good diagram from that. Again, this is all from Radiology Assistant. Here we can see the trachea, and this inferior to that is going to be your carina. And on the right side, your bronchus intermedius is going to form a short segment. And then you can see your left upper lobe bronchus here. And so the left main stem bronchus branches into its upper area over here. And this is more anterior, but signified by the red arrow. And then your lower lobe bronchus, which is your white arrow, and it's a little more posterior. And the right middle lobe bronchus courses anteriorly, basically, and it's just going to be caudal to the right pulmonary arteries across the right hilum. And so basically, here's your pulmonary artery, which is labeled, and your right middle lobe bronchus is just going to be, given off anteriorly here, signified by that white arrow. This was kind of a helpful diagram to split apart the basilar bronchi, and it's basically to draw an X, and then you can separate that into your superior, your lateral, your medial, and your inferior segmental bronchi. And so finishing up pretty soon. Basically, for the pleura, it's really important to know this information about how much pleural fluid it takes to become visible on a chest x-ray. So it takes about 200 to 300 milliliters of fluid before it becomes visible on a chest x-ray. Basically, and here's some diagrams showing that. After about 5 liters of pleural fluid, there's total opacification of the hemithorax. And so basically, this is just an example of total opacification of the right hemithorax in a patient with cancer, basically. And on the right, there's only just a little bit of air visible in the major bronchi, creating an air bronchogram within the compressed lung. And some important clinical anatomy regarding pleural effusions that they're very important. Here's a normal, and basically this normal chest, you can see that there's this sharp angle from the diaphragm, and then on this non-normal study, basically we're going to see this opacity that gets kind of more and more white as it goes down, and basically essentially what's going on there is there's obscuration by fluid, and that's why it's just becoming like that. And so when we take a look at the CT correlate on the same patient, you can see easily here that this blunted costophrenic angle and this increased density, or it's becoming more white on the right hemithorax, is basically going to have this appearance on a CT. And so this is the patient's right side, the patient's left side, and you can actually see there's a trace pleural effusion on the left side here. On the right side, it's quite larger, but basically this is what a CT correlate of a right-sided pleural effusion would look like. It's always important to look at the chest wall. Rib fractures are the most common identified chest wall abnormalities, especially these old chronic rib fractures. And so all these rib deformities here, you can kind of see these rib deformities here. These are due to old fractures. And sometimes when the fracture heals, it'll form, this callus, and it'll almost appear sometimes like a mass. So sometimes you even need a CT to differentiate between the two. And it's always important to take a look at the abdomen as well. The most obvious finding on a chest x-ray for the abdomen is free air under the diaphragm. So you always want to look on this on every single chest x-ray. It's not something you ever want to miss. It indicates a bowel perforation. Sometimes can be post-surgical, but basically it's something that needs to be noticed. And these are critical findings, especially when a patient has not had surgery recently, and we have to contact the clinicians about this right away. And so here's another patient with some free air. And, this is something that you just want to kind of get in the habit of looking for and pointing out all the time. So this is this one last case as we finish up here. Basically, this states, what is the most likely cause of the enlarged cardiac silhouette? It's always important to read all the answer choices: ischemic cardiomyopathy, atrial septal defect, sickle cell disease, or pericardial effusion. And one thing that they're giving us here, which gives us a huge clue to this disease, is basically this lateral chest x-ray. And if you can bear with me, and there's another example on the next slide if you can't really see this too well, but there's this opacity here that's going kind of vertically, and then there's basically a lucency, this kind of here, and then there's another one right over there. And so when you take a look at these opacities here and these lucencies, this one lucency thus behind the sternum, and then this other lucency that's thus behind this opacity that's vertical, that's something that we call the Oreo cookie sign, and that actually tells us that it's a pericardial effusion. And so here's some arrows to make it a little bit easier to see, basically, but we have this vertical line that's has more opacity, and then these lucencies that are this anterior and posterior to it. And this is, easily seen on the lateral. It's more easily seen on a CT, but this is just another example of that. This is the appearance of a pericardial effusion. And so you get these vertical opaque lines separating two vertical lucent lines, and it's more easily seen on CT. And so basically that was all I really had for you guys. I just wanted to go over some of the basics and go over some basic anatomy. I hope you find this helpful. This is my contact information. I just gave my personal email address because we're going to be leaving here pretty shortly. And so if anybody wants to ever reach out to me, feel free to. I'm going to be doing breast imaging. I'll be in Southern California. So if anybody's interested in breast imaging or interested in any, fellowships over in Southern California, please feel free to reach out to me anytime, and I'll get back to you as soon as I can. But I'd love to stay in touch, and best of luck to all of you guys. I really appreciate your time and patience, and hope you find this helpful. Thank you. Bye-bye.